I'm super interested in your background as an engineer.
Mm-hmm.
I took a look at LinkedIn, before I came to the office, saw you were at MIT. So MIT trained engineer, spent some time at Amazon, from what I understand, in various other capacities. So it's a pretty interesting resume for me, reading some of your accomplishments at every level. So let's take a step back and let's start kind of at the beginning.
Sure.
Why MIT? Why did you choose MIT? I'm sure you had your choice of schools coming out of high school.
So I grew up on the East Coast. I grew up in Maryland, in a family of doctors. My dad's a GI, mom's a PCP, aunt's an OBGYN, uncle's a cardiologist. Kind of been surrounded by medicine my entire life. And so for a really long time, I thought that was the path that I was going to go down. But what I realized is that I just love building things, and that there was a slightly different path I could follow that would really accomplish in both those things. I can build things while doing medicine, and that's going into med tech. A lot of that actually started from a super young age. My neighbor had a wood shop in his basement that he built out. He was a master carpenter. And a bunch of the time when I was young, I would go down there. We would just spend hours together just building cool stuff. I remember when I was 10, that was probably the first time I learned a valuable lesson, or actually even a little bit earlier. I grabbed the branding iron full on. I burned the hell out of my hand. And I learned you don't do that again. But I think those little things, just being down there, getting comfortable with equipment, getting comfortable with building things, it just made me realize how much I loved it and that I wanted to continue to do it. So I saw that I had this chance to go into medical devices and kind of blend those two different things. And I kind of always had this plan when I was going to college that I would try to focus in college on devices generally. And at MIT, I had this awesome chance to do mechanical engineering, electrical engineering, and computer science all wrapped into one. It's really mechatronics, but it gave me the chance to do all these different parts of a device, with the idea then being that I could go to grad school later and focus on the medical side of it. And MIT was this incredible place with really interested, talented people who wanted to solve creative problems and build really creative things. I was also getting recruited there for the water polo team, and water polo was a huge part of my identity growing up. I played for all the way from the age 10 through college. I played on the Naval Academy Club team growing up. It was a really big part of it. So it was a great opportunity to kind of blend all of those things together. And so at MIT, I loved the chance to work on all these things and combine them. I got to work at a bunch of different types of companies too, and different industries. I got the chance to get really involved with the extremely different kind of startup, and even pitch in the finals round of the MIT 100K competition, and just learn a lot from all of that.
And this startup did work with the Department of Defense, if I understand correctly.
This startup was actually in a very different field.
Okay.
It was founded by a couple of guys out of Harvard who I was working with in my freshman and sophomore year.
Okay.
It was actually about politics. It was about building a legislative platform so that people who wanted to get some kind of legislation passed for their own industry or to help specific groups of people, they could understand who in Congress to go talk to. There was a lot more built into it. They built out a lot from there over the past several years. It was a journalistic tool as well, like radically different than anything that I've done. But I did work with the DoD a little bit as well. I was with the Lincoln Laboratory, which is affiliated with MIT. And then I did an externship at Raytheon out in Florida. So got the chance to kind of get into those really deeply other kinds of regulated and secret industries.
Yeah, that's super interesting. And it sounds like the startup, you all were essentially trying to like automate lobbying to a certain extent, at least for the masses, right? Like the same way that general interests could, for example, donate and get in touch with these, congressional members, and senators, et cetera. You're providing a way for people to get access, everyday citizens to get access to some of those people.
Yeah, the way that I saw it was that it was about transparency.
Okay.
It was about politicians or Congress people, when they went out and they said that they sponsored or supported certain kinds of bills, you could see whether they actually did.
Mm-hmm.
And so transparency from a journalistic standpoint, like you said, for everyday folks who may not be aware of all of the ins and outs, because who is, but also companies who wanted to approach these folks, knowing the right people to talk to. And I thought the founders had a really interesting vision around that.
Okay, very interesting. So I'm curious, coming from a family of doctors, in practicing physicians,
yes,
How does your family feel about you now stepping into the entrepreneurial side to build in devices specifically, as opposed to going down the med school's track?
I think that when I was a bit younger, there was the kind of the assumption that I would go down the medicine path and try to practice. But again, my parents just saw that I liked building things too, and they were supportive of it. So I think the family overall, they get it. We have a lot of family history of diabetes, actually. So the specific problem that we're going after, they understand that too, and they see how valuable it can be. And you know what? They're helping support the journey throughout. I mean, as a sounding board, kind of across the board in a lot of different ways. I understand I come from a very privileged position in attacking the problem we are. And so I try to lean on them how I can.
Absolutely. Absolutely. That makes perfect sense. And I'm sure they're extremely proud. How did you end up making that transition from those opportunities into this particular problem that you're now working on today?
Yeah, definitely. So the thing about all these different opportunities in college and then post-college is that they all felt like, or several of them felt like different types of startups. So Quorum, the company I was with at the time, very much software heavy. I got to get my software chops with them. When I went out to Amazon Primera, which is where I went to after college, that was like a very, very extremely well-funded startup. And Amazon Primera was about using drones to deliver packages to people, and a lot of extensions from that. I got the great opportunity to work with a great team to basically design test machines for testing the entire propulsion system of the drone. It was an awesome experience, a ton of responsibility off the bat, a lot of high critical safety components to what I was building as well. Very high voltage, a lot of moving parts, very fast moving parts, and some expensive equipment I was designing as well, and got to see production of those parts and then transition it over to procurement and manufacturing. And I loved it there. I really, really loved it at Amazon. I loved Seattle, but I kind of always had that plan of going to grad school to do med tech.
Mm-hmm.
And so I applied to grad school while I was there, and I got into Stanford, and I realized that as much as I loved it, I needed to make this transition to follow the plan. So I came out to Stanford in 2018 for grad school. I did my master's in mechanical engineering, really kind of medical robotics, biomechanics. Again, I got to do kind of a blend of different things. I got really involved in the biodesign program, which helped take a lot of things I had seen in undergrad about entrepreneurship and apply it specifically to medtech. So while I was in the biodesign program, while I was doing the courses there and talking with the people there, I started spinning up the idea for Empo in parallel with my co-founder, Eric. And Eric and I have known each other for a decade. We were undergrads together. We were roommates together. We kind of always dreamed of founding a med tech company together, and the time was right now. So during that time, we looked at a lot of different problems, to be honest. But this issue of diabetic foot ulcers, it spoke to us immediately, and it was a really interesting, compelling one for me personally for a few different reasons. First, as I mentioned, a ton of family with diabetes, and I've seen how pervasive the complications can be. So I've always been interested in diabetes tech. This, of course, has that focus, but there's a few other components to it as well. One is that it's very orthopedics focused. I've always been interested in biomechanics. I've had a lot of sports injuries. And so something that has that pull has always been intriguing. And then the third point here is that diabetic foot ulcers are really, it's ultimately a big problem of care coordination as well, getting care to patients at the right time when they need it. So part of my personal journey with that is in college, at the end of my freshman year, I had a snowboarding accident, and I basically snapped my arm in half. I had a surgery. A couple things went wrong with it. About a month later, I had to have another surgery to correct some things.
Wow.
Yeah, and then a couple of years ago, I had a cleanup operation on it to try to take out the old plate. Some more things went wrong after that in the next few months, and ended up having to have a fourth one to put a bigger plate back in.
Wow.
So I grew up in a family of doctors, and even I had so much trouble navigating the healthcare system and had associated issues with it that for a lot of patients in our population who don't have that kind of access to care, you can imagine how much worse it is.
Absolutely.
So I think all those different things together made this really, really compelling problem. And combined with the fact that we saw that the right solution here had to be the blend of a medical device with kind of a consumer device type design that was so easy to use that it made sure the patients would want to use it consistently.
Yeah. Can you tell me a little bit more about diabetic foot ulcers specifically? What is it?
Mhm.
How is it currently treated today, and what are the trade-offs associated with it at the moment?
Definitely. First, I'll frame the overall scope of the problem we're dealing with here, because I think that everybody is just 1 degree removed from somebody in their family or somebody they know who's had a diabetic foot ulcer, or worse, a diabetic foot amputation because of it. But even then, I think that the overall scope of the problem still shocks people because they are staggeringly high numbers. So what happens is that half of all patients with diabetes in their lifetime develop what's called diabetic neuropathy. That means that they lose protective sensation in their feet, lose feeling in their feet ultimately. That means that they don't notice early signs of ulcers. So they may not notice an early wound or a pressure spot or a foreign body, like if they step on a piece of glass or a Lego, that can actually cause a lot of damage if it's unchecked. They don't notice those things until they lead to ulcers. Now, a quarter of all diabetic patients get these foot ulcers. In the U.S., that leads to over 100,000 amputations a year.
Wow.
And within 5 years of an amputation, half of patients actually die. So it is a crazy, pervasive, deadly problem. And because of that, it's a very expensive one as well. It costs 1/3 of all diabetic healthcare costs, up to 1/3. In the US, that's somewhere between $40 and $80 billion a year in diabetic foot ulcer spend. Globally, it may be up to $300 billion a year. So it is this crazy, pervasive, massively expensive problem. Now, the thing is that what we saw is that podiatrists, who are ultimately the ones who get the most involved once a patient loses feeling in their feet, they know that the solution to preventing severe ulcers is to detect them very early, right? So they ask patients to go home and visually look at the bottom of their feet every day. So they ask patients to do that. If patient sees anything at all that looks different, they're supposed to call up their podiatrist, and then the podiatrist will address that in a non-invasive way. The challenge there is that patients really struggle with conducting those daily visual inspections. And that's for a bunch of different reasons. I think that there's this tendency for people to think that patients with diabetes are just incompliant. And honestly, I hate that word. I hate that word compliance.
Yeah.
It basically implies that patients don't care, right? But they do care. It's just really hard to do it. They have to pick up the bottom of their foot and look at it. And for patients who have accompanying inflexibility, who have obesity, who have accompanying retinopathy, or just haven't been educated on what to look for, or even then they don't understand, it's not a reliable thing for them to do. So relying on that alone means that podiatrists right now are really lacking consistent and actionable observations from the home for these patients who have lost feeling in their feet. And ultimately, that's kind of the crux of the problem that leads to why diabetic foot ulcers are so common.
So let's say a patient comes home, they're able to perform the self-assessment, see changes, call up the podiatrist. Take me through, I guess, the stages of treatment once something has been identified for the patient, given the current state of treatment today.
Yeah, so it depends a little bit on what exactly it is that they see. The first step is typically going to be to bring the patient into the clinic. The podiatrist may ask a patient to take a photo of the bottom of their feet first, but that tends to be a tough thing for patients to do. If a patient tries to take a cell phone photo of the bottom of their feet, I have podiatrists say all the time that really that just means they're looking at the bathroom ceiling. It's really hard to do that consistently. And a lot of times somebody needs a caretaker to help do it for them, and not everybody has access.
Right.
So that means that the first step is to get the patient into the clinic most of the time. If it's a fresh open wound that's been that brought them in there, then they can typically treat that with wound dressings and antibiotics. If it's more of a pressure spot or a callus that has like a blood tinge underneath, indicating that there's some damage to the anatomy, then they can debride that callus, basically grind it away. That sounds bad, but it's actually really non-invasive. It's just like grinding down a corn or thick skin, and then address what's underneath. If it's something like a foreign body, they just need to pull that out of the foot. So it really depends. The thing you're trying to avoid is a patient not going to their podiatrist until they start to smell something from their foot. They start to smell an infection, which is really common, or until they start to see blood streaks, especially discoloration and pus from their foot. I know it's a little bit gross, but ultimately that's a lot of the time what ends up telling a patient that it's what makes them realize that something's going on. At that point, interventions start to get a lot more invasive. You start to get to much more invasive kinds of wound treatment. And ultimately, if there's an infection and that infection spreads quickly, it ends up leading to amputations. And those amputations will typically start one toe at a time, and then they'll go down a layer to the metatarsal, which is kind of the midfoot, and then below the ankle, above the ankle, below the knee. And that's when it starts to get really, really bad.
Wow. Okay.
Reulceration or re-amputation rates within around 2 years are actually around 50%.
You said re-amputation.
Re-amputation.
Meaning multiple amputations.
Yes. After a patient gets their first amputation, within 2 years, re-amputation is around 50%.
Wow.
Yeah.
Wow. So we have a 50% fatality rate within 5 years of an amputation period. And then within the same period, there's a 50% chance that a patient will have an additional amputation.
Right.
Wow. Okay. That is extremely problematic.
It is. Yeah.
Yeah. And that's a terrible experience, I think, for those who are suffering with that condition.
Everybody, them, their families.
Yeah, absolutely.
It totally affects everything about quality of life, as well as life expectancy.
Yeah. So can I ask you a question? And,
Yeah.
if you have the answer, great. If not, no worries. But I'm curious. For example, I've had blisters on my feet before. I've stepped on things. I think we've all had our fair share of cuts on our feet, right? Especially we were active children running around barefoot, etc. But mine heal without infection or anything like that. So what's unique about a diabetic patient that when they, for example, have a callus or an open wound, it progresses or it can progress in many cases all the way to an infection that leads to amputation?
So a few different things. One is that you would probably recognize it quickly. So you may shift pressure to a different part of your foot. You may even subconsciously shift pressure to a different part of your foot. If it's an open wound, you'll probably put on a Band-Aid. You'll probably use some kind of antiseptic, and you'll handle it that way. Patients here, they tend not to notice it until it's too late. And on top of that, they don't have those kind of subconscious signals telling them to shift how they step on things at the same time. In combination with all of that, patients who have neuropathy are often very comorbid with having peripheral arterial disease or circulatory problems that mean that things for them just don't heal as quickly either. And so they can progress quickly and they can't heal as quickly.
I see. Okay. Yes, because blood isn't able to make its way to the wound to then start the healing process because they're having circulatory issues along with the peripheral neuropathy as well.
Exactly.
Understood. So given that this is the framing and the context of the problem,
right,
prior to you founding Empo Health, what was the opportunity that you saw given the current state of treatment that led to the development and the strategy for developing your product with Empo Health today?
Yeah, so the opportunity that we saw was the conflux of remote patient monitoring becoming increasingly more popular and accepted, especially for specialty type conditions, and a solution space where it felt like some of the solutions that were coming up may not directly address the need that patients and providers directly had and how they were doing about it. We saw that what providers, again, mostly podiatrists, but also primary care physicians and wound care specialists and vascular specialists, what they kept saying over and over is we want to see patients' feet from the home. We want to visualize patients' feet. The way that we look at a patient's foot in the clinic, we want to have that information every day. And we saw that nobody was doing that. And the reason that it's very technically difficult to build a product that does that captures those images in a very private way in a device that can go into a patient's home that fits into their daily environment, that's easy for them to use every single day, in a really thin form factor that's safe for patients with a variety of different anatomies, or a lot of patients will have an amputation and be putting most of their weight on one leg, and a population that may be obese as well. So with all those different things, we saw there's an opportunity to design a new kind of device and then build a service around it that would allow us to address that.
What's the ideal standard for this type of data collection?
Yeah, so patients will typically see their podiatrist every 6 to 8 weeks for a regular diabetic foot care appointment. Most of the time, that's actually to cut their toenails, which
Interesting.
patients aren't supposed to do themselves because they could cut themselves and not realize it. So that's kind of that's the time frame we're working with right now, 6 to 8 weeks. So doing it weekly or biweekly, obviously that's already a huge step up, but the gold standard is to try to do it daily. And that's because issues can develop overnight. And we actually saw that in a pilot that we just ran. We had a few different patients who developed new wounds overnight that we were able to help use our service to detect very quickly so that they could be intervened quickly.
Okay.
So the closest that you can get to daily or near daily, the better.
Excellent. Okay. And so are you able to share a little bit more details about the product, what you built exactly, how it works, some of the success story that you've had from the pilot? I would love to learn more about that.
Definitely. So our product has 2 components. We've got our what we call our Empo footprint, which is a scale that a patient steps on, and it takes a full color scan of the bottom of their feet. It measures their weight. It does all of that in less than 2 seconds. It's really, really easy for them to just step on and step off. When it scans their feet, it uploads that data to the cloud, and they're good to go. Our remote health link service then is the service we built around it, and a remote health link portal specifically is where patients or their providers or Empo support staff can see that patient data, their images and weight data. And that can be done on desktop, mobile, or tablet. So they can interact with it there. They can see if something looks different, start to make decisions based on what to do, and stage early interventions if necessary.
Interesting. And this is a mobile application, the cloud service, or a web app, excuse me, or you have mobile app, etc.
Yes, it's built for desktop, mobile, and tablet.
Desktop, mobile, and tablet.
Yep.
Okay, cool. Sorry, I wasn't sure if they were accessing it via web app, but
yeah.
Well,
that's actually it's an important point because a lot of patients who are at high risk of foot ulcers because they have neuropathy, they tend to be elderly patients. And interacting with them strictly through a mobile app actually tends not to be the best way a lot of the time. Utilizing things like phone calls and text messages is actually much more effective, but all patients do have access to their data through the portal, and they can access it as they need to.
Yeah, and I think that's interesting to me as well. And I'm curious, why is it important for the patient to have this particular data as opposed to it just being sent to the podiatrist or their primary care physician?
Well, a lot of it is about empowering the patient. Part of what Empo means is empowerment, right? We actually saw this during the pilot that we ran. I gave the example earlier of stepping on a foreign body, right? If you or I were to step on a Lego, it wouldn't seem like it's that big of a deal because we know it hurts and we would take it out. But a patient who steps on a Lego and doesn't realize it, if they go and they walk around for a day and they come back, they could do a lot of damage to the anatomy underneath their skin, and then that could quickly open into a wound and then become infected. So we had a patient during the pilot that we just ran who actually did have a foreign body stuck in his foot, and he had no idea. So he was able to see the data, see the images, and that became a useful teaching tool for the care team as well to show the patient why he shouldn't be walking around home barefoot. And he had no idea before this, right? I mean, he had been told by his provider not to walk around home barefoot, but he's got a lot of different things going on. He may not have realized the extent to which it mattered. And then this showed him exactly why.
Absolutely.
So that is empowering the patient.
Absolutely. And it helps them participate in their own care and obviously get ahead of some serious issues that could arise later down the line, as you mentioned, which is so common for those who have diabetic foot ulcers.
Exactly. And potentially empowering their caretakers as well, whether it's their children or their spouses or anybody else who wants to have access to that data. Once they will be able to do that through the portal, their different features will roll out over time, but we want to empower them as well to know that their loved ones are being taken care of and to participate in that care.
Yeah, absolutely. Absolutely. That makes total sense. And so talking about the ideal cadence for someone to utilize your device, to step on that scale, I think it's brilliant, first of all, that you've made it a scale, right? Because that can simply replace an existing weight scale. It serves a dual function, one of which is reporting someone's weight on a daily basis, which is a very common thing we all do if we have scales at home. But at the same time, you kind of used a Trojan horse, essentially, to kind of get that additional benefit out of it, which is that visualization of the bottom of their feet that you can send and reveal to the patient So that way you can get ahead of some of these issues that they may have down the line in terms of diabetic foot ulcers.
Yeah, exactly.
Yeah.
And Eric and I iterated on different form factors for the product before we settled on the scale definitely being the right one.
Can you tell me a little bit about that? Like, how did you arrive at that form factor?
Sure. First, one thing we tried was a more of a bath mat type design. So something that would dry patients' feet while it also captured that image of their feet. And we put a lot of devices in a lot of people's homes, a lot of patients' homes too, to try to collect data. These were mechanical mock-ups at the time to understand how they felt about it. So there was interesting there, even if it were effective at drying their feet. One thing we saw is that a lot of patients with neuropathy have been told, don't step on a hard surface with wet feet because you may slip. And so even if the surface that we gave them, the device that we gave them, was safe for them to step on and would dry their feet, it just had a bit of a weird feeling for them. And then that led to that not being the right form factor. There were other ones to look at as well, like something that could be near the toilet, things that are more like stepping stools. But ultimately, what we saw from all of our testing is that a device to really integrate into a patient's home reliably had to be a scale. It had to be less than around 2 inches thick. And so that's where we ended up. Yes.
You have a current pilot in process right now that you rolled out.
Right.
Tell me a little bit about how that pilot is going. Have we achieved the ideal cadence of daily use in terms of the use of the scale and the medical device for these patients?
Yes, we definitely have. So we have rolled out our product in a pilot, a usability study really, with around 20 patients for now around 5 months. And we've done that with 3 private podiatry practices. Over the past 5 months, we have had 26 days per month median usage.
Wow.
So really near daily usage. And on top of that, we, out of those around 20 patients, for 7 of them, we helped use our product to detect early signs of ulcers. So 4 cases were emergent wounds that were detected in time well before they got infected. 2 of them were more subcutaneous issues that hadn't yet broken the skin. They got detected at the right time. And then the last one was the foreign body case that I just mentioned. And on top of that, we saw that we did not miss any ulcers during the study. And we know that because patients continue to come in for their regular diabetic foot care visits every 6 to 8 weeks. That's the intended plan. They need that anyway. And we know that we did not misidentify issues because of the actions taken by the care team.
Wow.
Yeah, thank you. So we are very, very happy with how that turned out.
Absolutely. 26 days, 27 days?
Yeah, 26 days.
26 days?
Over a 5-month period.
Over a 5-month period, averaging 26 days a month.
Yes.
That is a testament.
Median 26.
That's a testament to your design. Like how well you all have integrated into the patient's lives. Like just what you mentioned not too long ago, right? It's you figured out a way to seamlessly integrate into a patient live. And I think that's the metric, right? Like that's the KPI that is indicative of that. 26 days on average, that's fantastic.
I appreciate it. Thank you. And I think it also speaks to the empowerment piece here, right? Patients do care. Even if all the patients in our study had a history of ulcers, which people may point to them being previously incompliant, they do care.
Yes.
And it just has to be really easy for them to use it. And when they know that if they can just step on our foot on their footprint device, it's going to capture a high quality scan of their feet. They know they'll be able to see it if they want. They know that it's giving their provider useful information. All of those things together, they want to do it. It becomes second nature.
Absolutely. Absolutely. Incredible work. Milestones.
Yes.
That's a key milestone. That's fantastic. This is outstanding information, outstanding news. Congratulations on that so far.
Yeah.
Leading into the next 6 to 12 months, what are some of your key milestones over that time period that you guys are working towards now?
Yeah, the biggest one is that we're launching our product to market early next year. So we have a number of practices and customers lined up. They have a huge number of patients who will start using this, and it's going to be exciting to start getting this out there commercially. We ran this pilot as close as we could commercially, but now when we actually get it out there, we'll be an FDA Class 1 exempt listed product. We'll be able to start truly commercializing it.
That's fantastic. And that's all going to happen within the next 12 months. Is there anything else you all are targeting in this rollout of commercializing the product and getting it out to more podiatry practices?
Yeah, so it's about showing that it works commercially with those practices. It's also about generating more and more data to prove that in the long run, our product really can help cut down on amputations, hospitalizations, and ER visits in severe ulcers when it's used by patients with their care teams, with Empo support staff overall. That the entire service together can really help improve those outcomes.
Absolutely. And speaking of data, do you think about the repository of data that you're collecting of visual images
Yes.
that could definitely be valuable from an AI model standpoint?
Definitely. I think that in this day and age, especially, truly proprietary AI and algorithms are trained on proprietary data sets. And proprietary data sets ultimately are most effective when they come from proprietary hardware. So we're building the world's first repository here of fully weight-bearing images. Over the long run, we're going to look at building in features for automated risk prediction and diagnostic capabilities. There's other modalities that we're looking at as well that could be really exciting and expand overall indications for use and where this product can be used. These are all definitely areas that we're working on as well. And they're all powered by the richness of what you get with visual data.
That's amazing. I feel incredibly privileged that I've had time to sit down and talk with you, Anuj. It's an absolute honor that I have the chance to work with you. And I'm thrilled and just incredibly grateful to have the opportunity to witness you build Empo Health from an early stage company into a company that's going to be transformative in the lives of diabetic patients moving forward. Before we conclude the conversation, I want to know, are there any final thoughts that, you have around the state of care, as it relates to diabetic patients, where the industry is headed in terms of remote patient monitoring and at-home care, and how you all are positioning yourselves to be a key leader in this space for many, many years to come?
Yeah, well, first, let me say thank you. I mean, I really appreciate you doing this and setting this up, and it's a privilege to work with you as well and to continue to build all of this together. I think that, well, I have a few different thoughts on the overall diabetic foot ulcer space in particular. I think for one, there's a lot of focus that is justifiably and should be given to helping control glucose levels, behavior change in the early days, trying to help prevent patients from getting to the point that they develop things like diabetic neuropathy and retinopathy and peripheral arterial disease. But an equal focus needs to be given from that point on. Diabetic foot ulcers are not a sexy problem. I know that. But they're a huge cause of mortality. So I think that once patients end up in a high-risk category, the same amount of attention needs to be given to helping them improve their overall quality of life and reduce the loss of life that happens at that point. So I feel very strongly about that. I think that also in this space, there's a lot of different important clinician groups to listen to. I feel very strongly that, we try to champion podiatrists here. We think that podiatrists, by and large, when patients have neuropathy, they should be seeing podiatrists. Podiatrists are frequently dealing with this problem and trying to help patients kind of act as psychologists and endocrinologists and primary care and vascular. Patients should have all their specialists, but podiatrists will also be a single point, bringing a lot of those things together at the same time as well and helping educate patients and seeing them on a more frequent basis. And we want to try to empower them and listen to them and see what it is that they say they need, which is reliable visual images. Beyond that, I think that what we're trying to build at Empo, it starts with diabetic foot ulcers, but there's a lot of angles and avenues and indications for use that we can go to in the future, especially as we bring in different types of modalities. One thing to keep in mind too is that we've talked about all of this, peripheral neuropathy from a diabetic standpoint. There's a huge population of patients. It may be over 30% who have peripheral neuropathy, but it's not even caused by diabetes. You can get peripheral neuropathy from kidney disease or alcoholism or chemotherapy or just getting older. It can be called idiopathic neuropathy, meaning nobody knows the exact cause, but all of those patients are at very high risk as well. And so, we're focused on diabetic patients as a very controlled population who most frequently experiences this problem, but the overall population is much bigger than that too.
Absolutely. Well, diabetic patients in the United States deserve a passionate founder like you, who's dedicating his life to building health solutions for them and to participate in improving their lives through, prevention and exceptional medical care moving forward. Again, it was great to talk with you, Anuj. Again, thank you so much for the conversation, and I'm looking forward to the next one and seeing what you build in the meantime.
Thank you. It's been a pleasure.